statement? Which of the following statements is false regarding respiratory acidosis? More hydrogen ions are excreted by the kidney. Bicarbonate is excreted by the kidneys. Bicarbonate is generated by the kidneys, or there is increased concentration of bicarbonate in the body. Answers.
I think it's that bicarbonate is excreted by the kidneys because we need to really absorb our bicarbonate if we are having acidosis.
That makes sense. But what about A?
If the question is asking what is false regarding respiratory acidosis, okay, I guess B makes sense. But during acidosis, do you generate more of the bicarbonate ions?
Yeah, you do.
Okay, so what about A?
See, that's true. More hydrogen ions will be excreted by the kidney because you have too much hydrogen ions. There's increased concentration of bicarbonate in the body. See, that will also be true.
Yeah.
Yeah, through compensation. Remember the question is asking which one is false. And even on that note, I will need someone to take us through this acid-base balance. We look at the two types of acidosis, two types of alkalosis, and the buffer systems in the body. So someone who has content in either in any of those areas, respiratory acidosis, respiratory alkalosis, metabolic acidosis or alkalosis, and even the acid-base balance in the body, the buffer systems of the body. Please unmute, just tell us what you know so that we can also move fast, kindly.
Guys, I've sent the pictures on the group. Maybe somebody can just take the lead and go through it. It also has treatments and the causes. Because I know in one of the, even the next question, it's asking the causes of metabolic acidosis, alkalosis. So maybe somebody can take the lead and take us through.
Great. Dr. Mary, I think you are done muted. You wanna take the lead on that?
Not really. I would say for number one is D, because there's sometimes back somebody sent us something on the group that was showing the levels of carbon dioxide, bicarbonate, the pH, and the ventilation. When you have metabolic acidosis, the carbon dioxide levels will be high, the bicarbonate levels will be low, the pH will be low, and ventilation will be normal. For metabolic alkalosis, the carbon dioxide levels will be low, bicarbonate will be high, the pH will be high, and ventilation will be normal. Respiratory acidosis, the carbon dioxide level will be high, bicarbonate levels will be normal, pH will be low, and there will be hyperventilation. And for respiratory alkalosis, the carbon dioxide levels will be low, bicarbonate levels are normal, pH will be high, and there will be hyperventilation. So this D, that there's increased concentration of bicarbonate in the body, will be false, because bicarbonate levels in both respiratory alkalosis and acidosis is not. That will be my take.
But on that, let me just ask, when we always say when there is acidosis of one system, counting it as respiratory versus metabolic. When there is acidosis or alkalosis of one system, the other system compensates. So when there is respiratory acidosis, the body will compensate by kind of doing metabolic alkalosis, increasing the concentration of bicarbonate in the body. So
Yes,
those are my,
I agree with Gaius. There will
Yes,
be an increase in bicarbonate.
I agree
because
with
of
Gaius because
yeah.
I have something to add on what Gaius has said. When there is respiratory acidosis, it will be corrected by metabolic alkalosis at the kidney level. So meaning, more hydrogen ions are excreted by the kidney. That's right, bicarbonate is excreted by the kidney. No, you have acidosis, meaning you need to have more bicarbonate to buffer the acidosis. So I think the correct choice will be bicarbonate is excreted by the kidney. That is wrong. We need more bicarbonate. So C, bicarbonate is generated by the kidney. That is right to buffer the acidosis. And D, there is increased concentration of bicarbonate in the body. Yes, that is right. So the correct choice is B.
Great to, let me just go through this diagram that has also been sent on the group of the pH imbalance. Just a second. Yeah, so let me start with the one that we are discussing currently, respiratory acidosis. Respiratory acidosis, this is as a result of accumulation of CO2 due to decreased excretion by the lungs. So decreased carbon dioxide levels lead to pH imbalance. So common causes will be COPD, asthma, pneumonia, pulmonary edema, and respiratory failure. So in respiratory acidosis, it's as a result of accumulation of CO2. Hence, because the lungs are not able to excrete that CO2 properly. So we are seeing the common causes will be respiratory issues such as asthma, COPD, pneumonia, respiratory failure, all of those, COVID-19 was causing this thing. The lab values, of course, the pH will be decreased, the CO2 will be increased, the bicarbonate will be normal or decreased. The cause is the lungs are not excreting CO2. The kidneys will control the bicarbonate levels. That will be the metabolic compensation that we are talking about. We know the normal pH of the body is between 7.35 to 7.45. So when we say decreased, we know what we mean. So for compensation, we'll be having the kidneys will respond to increase CO2 by doing what? Number one, by increasing bicarbonate reabsorption or concentration. This will result in an increase in the pH. That is how the body will compensate. Treatment, we go to treatment. We are having bronchodilators, steroids, BiPAP or ventilator to assist breathing, or renal system increases the bicarbonate concentration. So we can see the medications are mostly based on the cause. So if it's COPD, asthma, this person needs to be taking these bronchodilators to help in the breathing. If it's respiratory failure, ventilator assisted breathing will be applied. Moving on to respiratory alkalosis. So acidosis we've seen in this accumulation of CO2. Alkalosis, when it's respiratory alkalosis, it means having decreased CO2 levels. Let no one ever tell you that we do not need carbon dioxide. We do need carbon dioxide in the body. So respiratory alkalosis is as a result of decreased carbon dioxide levels due to increased excretion by the lungs. A very common cause of that will be hyperventilation. Someone breathing fast, hyperventilation. So you're removing all the CO2 that you're having. Because the pH will be increased, the CO2 will be decreased. And the cause we've said is the lungs are excreting too much CO2. And remember, it's now respiratory alkalosis, so there'll be metabolic compensation by the kidneys. The kidneys, they will decrease, or rather they will excrete the bicarbonate. That is how they will respond to the same, resulting in a decrease in the pH. Treatment, just fix the underlying cause, address the anxiety, assist the client with relaxation. So hyperventilation will lead to that respiratory alkalosis. Yeah. Common cause of that is stuff like anxiety. Moving on to metabolic acidosis. Now, when we come to metabolic acidosis here, in respiratory, majorly we're looking at the CO2. In metabolic, majorly we'll be looking at the bicarbonate. So in metabolic acidosis, we'll see it's an accumulation of acid in the body caused by increased acid generation or loss of bicarbonate or diminished renal acid excretion. Yeah. So in short, there is excess acid and decreased bicarbonate. Common causes: renal failure, antifreeze overdose, or I think that stands for aspirin overdose. I don't know, acetylsalicylic acid, diarrhea, diabetic ketoacidosis. Yeah. So those are the common causes of the metabolic acidosis. Just to highlight something, that diarrhea would cause metabolic acidosis, whereas vomiting would cause metabolic alkalosis. Diarrhea, acidosis; vomiting, alkalosis. Yeah, just differentiate between the two. So for the metabolic acidosis, we are having a high pH. Of course, when it comes to the treatment, always fix the underlying cause, and you can treat symptomatically using sodium bicarbonate to raise the pH. And how will the body compensate? It will increase the respiratory rate to decrease the CO2. Remember, we said when you're hyperventilating, you're losing CO2. So that's the way the body will compensate, by losing the carbon dioxide. So you will hyperventilate in case of metabolic acidosis. Lastly, metabolic alkalosis. This would be caused by an accumulation of bicarbonate in the body, caused by loss of stomach acid or excess bicarbonate. Yeah. And this would lead to, also, it will be accompanied by hypokalemia. Remember, someone once told me this mnemonic: alkalosis. The symbol for potassium is K. So when you say alkalosis, potassium is low in alkalosis. You know, that will help. So in alkalosis, we'll see potassium being low. Common causes, remember we said vomiting is one of the most common causes of metabolic alkalosis. There's a loss of stomach acid caused by that vomiting, or even the excessive NG suction, the nasogastric suction. Compensation, it's metabolic alkalosis, so we'll be compensating through respiratory acidosis. The body will decrease the respiratory rate so as to retain more of carbon dioxide levels, so as to retain more of CO2, leading to compensation, or rather leading to a decrease in the pH. Yeah. I think that's more of a summary of what has been sent, unless now someone has something to add on the same. So we can all agree for choice, for number one, that bicarbonate is excreted by the kidney. That is false. The kidney will be reabsorbing as much bicarbonate as possible. So number one, choice boy. Metabolic alkalosis. We've just covered this now, that that one will be caused by vomiting. Diarrhea, we've seen that is acidosis will result. Renal failure, we've seen also acidosis. Respiratory failure would cause respiratory acidosis. Actually, all the others cause acidosis. Hey, Hiral, let me not steal your show. You can continue.
Okay, so number 3, assessment of renal function involves measurement of all the following except. I don't think we need to even, the answer would be zinc. All the others are measured. Elevated levels of aldosterone is associated with Conn syndrome, diabetes insipidus, pheochromocytoma, and thyrotoxicosis. I would go for B, diabetes insipidus. What is Conn's syndrome?
It's primary aldosteronism. So it's where you have increased levels of aldosterone produced by the adrenal glands. So it's called, that's Conn syndrome.
Oh, sorry.
Yeah.
In diabetes insipidus is less
Yeah.
ADH. Okay, yeah, sorry. Okay, so everybody agrees that A is the answer.
Yeah, true.
Okay. For C, pheochromocytoma, I think it's increased catecholamines. Yeah. And thyrotoxicosis is with the with the thyroid gland, which is hyper, like it's increase thyroid hormones. Okay, so number 5.
Viral, before you go to number 5, what's the difference between hyperthyroidism and thyrotoxicosis?
I think thyrotoxicosis is a severe event at which you have very high levels of T4 and T3, and therefore this leads to like excessive effects of what the thyroid hormone will cause. So it's an emergency case.
Yeah, or maybe just prolonged hyperthyroidism.
Okay, thanks.
So I have a question. The Conn syndrome is similar to or the same as syndrome of inappropriate ADH.
I think Conn syndrome can be a factor which plays a role too, you having SIADH, but there are several causes.
Okay. Okay, fine. Okay, then number 5, insulin does not promote glucose uptake by cells, glycolysis, lipolysis, and hypoglycemia. Lipolysis, right? AI is saying syndrome of inappropriate ADH is a renal issue. Therefore, there is no response to ADH. Okay, thank you. So number 5.
I think you're right. It decreases lipolysis. So it does not promote lipolysis.
Yeah. Anybody with a different answer or explanation? Lydia, you're saying B. Why B? Oh, C. Okay, fine. So we can move on to the next question. Okay. The following are causes of hypophosphatemia except decreases absorption, intracellular shift, increased renal losses, increased vitamin D secretion. Gas is saying D. You can explain to us why D?
I was on my way to confirm, but I thought vitamin D does promote the reabsorption of phosphate ions or phosphate. But let me just confirm that. Then, but if someone is sure, they can also help.
Okay, mostly I think for me I would do like what's it called? Removing the other choices. So increased renal losses, then definitely it means there's gonna be loss of ions, which will lead to hypophosphatemia. Decreased absorption will definitely also be a cause, because it means your body is not absorbing as many of the ions as you're supposed to. So we can be safe to assume that phosphate ions are also not being absorbed, and intracellular shift could also cause a decrease in the hypophosphatemia. And remember in network elimination method. So I would be left with D.
Someone is asking what is intracellular shift?
I've confirmed that, yeah, vitamin D does increase phosphate absorption. Yeah.
So vitamin D, I have a question. It's related to calcium absorption and phosphate absorption, right?
Yeah. Calcium, yeah, and phosphate.
Okay. So if we're talking about hypophosphatemia, we're talking about hypocalcemia.
And if we are talking about hyper or hypo?
Hypo.
Hypophosphatemia.
Yeah, if we're talking about hypo, the one that's mentioned, are we also saying that there's hypocalcemia? As in, I know maybe it's not related, but like for example, in hypoparathyroidism, you have hypocalcemia, right?
Yeah.
So that means there's also hypophosphatemia.
Okay, I'd say that it's you'd need to test the calcium level if you find hypophosphatemia, because it may be a vitamin D issue, so they may be also hypocalcemia.
Okay.
Yeah, so, yeah.
Yeah, and Nugal is saying that it's opposite. If it's low phosphate, then it would be high.
Yeah,
high
so
calcium.
I think we can do what Sam is suggesting. We revisit the parathyroid hormone and its actions, and I think in the same line we can briefly look at hyper and hypoparathyroidism. Mentioned a lot on thyroid, but not mentioning para.
And someone has asked, what is intracellular shift?
What is intracellular shift? So I'd say intracellular shift, from what we mentioned when we were talking about the sodium potassium ATPase, is when stuff moves into the cells. We know phosphate is a major anion of the intracellular environment. So my assumption is when there's that intracellular shift, we've had more phosphate moving into the cell, hence leading to a situation of hypophosphatemia. Oh yeah, so we're waiting on somebody to mention physiology of the parathyroid gland, not the parathyroid gland, more of the parathyroid hormone. What are the actions of the parathyroid hormone? Anyone, real quick, real quick.
Okay, so I've sent something on the group. So when there's decreased plasma calcium, the parathyroid hormone is secreted by the parathyroid gland. So what it does in the kidneys, it stimulates the reabsorption of calcium, but inhibits the reabsorption of phosphate. And then even from the kidneys, it also stimulates, or there is increased vitamin D3, which now stimulates absorption of calcium and phosphate from the gut. And on the bone, it stimulates the dissolution of calcium phosphate crystals. So all these leads to increased calcium. So when there's decreased plasma calcium, then parathyroid hormone will be secreted. And then in case where the calcium is increased in the plasma, then calcitonin is released. What calcitonin does, it stimulates the excretion of calcium and phosphate in the kidneys, and it inhibits resorption in the bone, thus decreasing the plasma calcium level. Yeah.
Thank you, Hiral. Thank you, Hiral. So as a summary, just on calcium, you'd say it increases calcium, it decreases phosphates, right?
Yes, but that's just in the kidney.
And on the bone?
On the bone, it's just for the calcium, but when you stimulate vitamin D from the kidneys, it increases the absorption of both calcium and phosphate.
Okay.
Can I add something on the same?
Yeah.
The first thing when you hear parathyroid, just remember it increases the blood calcium. So what it will do, it will promote osteoclast activity in the bone. So meaning bone resorption will increase to increase calcium level in blood. And at the intestine level, it will promote both calcium and phosphate absorption. And at the kidney, it will promote calcium absorption, but phosphate will be excreted in the urine. Yes, thank you.
Yeah, so when we're talking about hypo.
Hello.
Mhm. Lydia, you wanted to say something? Okay. Yeah, so when we're talking about hypoparathyroidism, that means these low levels of calcium in the plasma, because since we don't have the parathyroid hormone to increase the levels of calcium. So yeah, hypoparathyroidism leads to hypocalcemia. Then for hyperparathyroidism is now the opposite, where there's a lot of parathyroid hormone, which now keeps on increasing your calcium levels in the blood, causing hypercalcemia. Yeah. Should we move on to the next question?
And then also,
Mhm.
okay, this is more of clinical pharmacy, I guess. I'm not sure if it's that relevant. Like in CKD, there's usually hyperphosphatemia because there is decreased excretion of the phosphate ions, but then we have hypocalcemia because of reduced vitamin D from the kidneys. So while we're treating that, we should first treat the hyperphosphatemia before treating the hypocalcemia, because when you treat the hypocalcemia first and we have calcium again being absorbed, the calcium will precipitate with the phosphate because of the high concentration. So we first treat the hyperphosphatemia, then now the hypocalcemia. Yeah.
Yeah, okay. So Pablo is asking, so when calcium is reabsorbed due to effects of PTH, is phosphate reabsorbed along with it, or it is excreted? In the kidneys, the phosphate will be, it inhibits the reabsorption of phosphate. So therefore there's increased excretion of the phosphate. Like on the picture that I've sent, it shows on the kidneys, it stimulates the reabsorption of calcium and inhibits the reabsorption of phosphate. Is that okay? Okay, I guess we can move on to the next question, unless anybody else has another question. Okay. When calcium is reabsorbed in the kidneys by the process of active transport, phosphate is reabsorbed passively along with it, as both are positively charged ions. This process ensures that the balance of phosphate and calcium in the body is maintained. What about this? I'm not too sure, unless anybody with an answer to that.
No, based on what was said, when calcium is reabsorbed due to PTH, then phosphate will be lost. Phosphate is not reabsorbed with calcium. Phosphate will be lost because, and then also the other statement, phosphate is not positively charged. It's negatively charged. Yeah. So when calcium is reabsorbed due to PTH, phosphate will be lost.
Okay. So next question, which of the following is used as an indicator for cholestatic liver disease? Alkaline phosphate, alanine transaminase, aspartate transaminase, or lactose dehydrogenase? Divya says A. Anybody else with a different answer?
Me would have gone with D.
Sorry, Will, you said you would have gone with
Trace dog.
the lactose dehydrogenase.
Yeah, because I think ALP, ALT, and AST together with GGT can be used as liver markers generally. Lactate,
But that's
lactate
what it's asking.
or
Yeah.
this ALT and AST can't be used as liver markers. Sorry. For cholestatic, I'm just wondering, can someone? You get, like, I'm wondering if the question was meant to be not an indicator, because all the others are liver markers, but I'm not sure if they're cholestatic liver disease markers.
You see, cholestatic liver disease and liver disease are two different things. I think cholestatic is like blockage, I think, but I'm not too sure. So if it was just liver disease, then it would have been B and C.
Also,
Someone just correct me. What is cholestatic? Is it due to blockage? Yes. Now, because of blockage, yeah, ALP, GGT, and I think that nucleotide receptor transaminase. I don't remember the other one, but yeah, ALP and GGT are the ones for cholestatic, and then AST and ALT would be for now liver disease or hepatocellular damage. Yeah.
Oh, thanks.
Someone, Shina asked if we can do an overview of cholestatic liver disease. Somebody can take us through that, please.
Yo, guys, please, time is really running. We need someone to volunteer. Perhaps cholestatic liver disease may just be alluding to where there's a blockage of bile flow of the bile duct, but as a general, to cover these diseases, we can cover in form of pre-hepatic jaundice, hepatic jaundice, and post-hepatic jaundice. So someone who is well-versed in that area. Please unmute and tell us what you know. You don't have to know all the jaundices, just unmute on the one you know. Stanley, Kigo, Michelle, Scooby-Doo, please unmute. We know you know these things.
Okay, Fatma has sent something on the group. So cholestatic liver disease, it's decrease in bile flow through bile ducts in the duodenum. So basically blockage mostly. Causes impaired secretion of bile from the hepatocytes, and also elevated levels of estrogen, because estrogen causes the breakdown of cholesterol into bile acids. Then yeah, so it can cause jaundice, and I think that is now the extra hepatic, what is it called, extra hepatic, yeah, obstruction, like jaundice related to that. Diagnosis, we just said the liver enzyme, the enzymes. Mostly GGT can also be increased due to alcohol. And medication, the treatment for this would be fat-soluble vitamin supplementation and deoxycholic acid, which increases bile formation. Yeah, and also surgery now to remove the blockage. Yeah, I guess this is okay. Okay, then we can just go to the next question. An increase in the number of cells in the human body is referred to. Number 8 is B. Yes. I think we can move on. We've discussed this before. Which of the following is not associated with acute inflammation? Redness, heat, swelling, or atrophy? Yes, D. What are the 5, is it 5 or 4 signs of inflammation? 3 are already mentioned. What are the other 2? Swelling, heat, redness. Then
Pain.
pain, and yeah. Then I think there's a last one, which is, I think, loss of function. Yeah, loss of function. Okay. The following conditions can cause hypercoagulability of the blood except myocardial infarction, breast cancer, bone fractures, and thrombocytopenia. Thrombocytopenia, I'm not sure. Yeah, thrombocytopenia. Anybody else that wants to add anything on this or wants to discuss? Okay. Anna, Divya, you want to discuss what exactly? Like how each one causes, or why not B, breast cancer? I think because of the increased estrogen, but I'm not sure. I don't know if that makes sense.
The other thing, generally with cancers, we say cancer is a pro-inflammatory state, and inflammation favors coagulation or clot formation. Yeah, so all cancers, there's always that risk of hypercoagulability.
Thank you, Gaius. An appropriate counseling point for a female purchasing intravaginal miconazole is to avoid usage during menstruation. All male partners should be treated concomitantly. Avoid concomitant use of external creams. Side effects may include burning or sensation. HP says D. Anybody else with a different answer, explanation? Miconazole is used for what?
Miconazole is used for candidiasis, but it's normally given like for the recurrent vaginal candidiasis. Say you've used the clotrimazole and the infection keeps recurring. So I think it's like is it called second line treatment? So once you use the clotrimazole, it doesn't clear or the infection keeps recurring, then you'll be advised to go now for miconazole.
Basically refractory cases.
Yes. Yeah.
Okay. So then is everybody okay with D? Because I've seen some patients may experience side effects such as burning, itching, irritation, and redness at the application site. These side effects are usually mild and go away on their own, but can be managed by using fragrance-free or soothing cream. Okay, so then D.
I'm not comfortable with D because side effects of miconazole may include burning and sensation. So I'll go with C because avoid concomitant use of external cream. Maybe, for example, you're using miconazole and clotrimazole, topical application of miconazole and intravaginal miconazole. There is definitely no issue in that. So for me, I'll go with C.
Okay. Someone is asking why not B? All male partners should be treated.
So there are articles that have shown that even when you treat the sexual partner of a lady who's suffering from recurrent candidiasis, it has no significant impact. Because remember, it's not sexually transmitted.
Well, let us use elimination method. So D cannot be the answer because more common side effects of miconazole is itching skin. Avoid usage during menstruation. That's okay. All male partners should be treated. Number B, this is because if you have candidiasis, what is there is that candidiasis can also affect men, but rarely. So B can also be a factor. I think it is C.
I think we can put a star on that question so that we can proceed. But I know a general, something about creams in general, a canceling point is always that they can all cause some burning or some sensation or some irritation. That's a general canceling point with anything topical. So I'm personally, I'm also supporting D, but I understand why also C can be an answer. So you can just put a star and proceed.
Okay. So next question, which of the following agents is used in prinzmetal angina for spasmolytic actions which increase coronary blood flow? B, yes, I would also go for B. We know timolol and propanolol should not be used in such a case. Beta blockers worsen the symptoms for this type of angina. Yeah. Think calcium channel blockers are the ones that are mostly used for such cases. Yeah. Anybody else wants to add or clarification? Can you say calcium channel blockers dilates the arteries? I think they do dilate arteries. Okay, then which of the following antihypertensive drugs may cause dry cough? This we know it's captopril, ACE inhibitors. Yeah, don't think we need to discuss this. It causes increase in bradykinin. Yeah. Long-standing hypertension leads to tissue damage in the following organs except heart, lungs, kidneys, brain. In HB is saying B. In the lungs, I would also agree. Lungs. Anybody else with a different answer? Okay, then we can move on. Which of the following is used as first-line therapy in heart failure due to its cardiac remodeling effects? Hydrochlorothiazide, carvedilol, furosemide, or ramipril? Yes, ACE inhibitors are used because of their cardiac remodeling effects. Yes, everybody agrees with that. Kinda, okay. So we move on to the next question, or you guys want to discuss? Okay. The following drugs are appropriate therapies for a lower urinary tract infection due to what is cardiac remodeling? I'm not sure, but I think cardiac remodeling is due to the effects of angiotensin 2 on the heart, which causes the heart to change its structure from being elliptical to spherical. I'm not too sure about that. Anybody can correct me if I'm wrong, or talk more about cardiac remodeling.
Yeah, Hiral, it's what you said. Yeah, that change in shape from the elliptical to less spherical, and stuff like the extracellular matrix changes, the myocyte also size changes, just the remodeling of the normal cardiac tissue.
Yeah, it usually occurs like as a compensatory adaptation because there's like a lot of stress on the wall of the heart. So it's because of angiotensin 2 and aldosterone. Yeah.
Okay, if I can say what is remodeling. Cardiac remodeling is where the cardiac muscle, because of either increased pressure, the cardiac muscle will be trying to pump too much or too less because of the increased pressure in the cardiac. So it must have to compensate for the volume that is reaching the peripheral, or even the volume that is remaining in the heart, in the ventriculars. So it has to help increase in pressure to compensate for the volume reaching the peripheral. It will have to pump more. So cardiac remodeling, it will have to cause changes in the structure, in the cellular bodies, molecular. It is not a good thing. So the ACIs and the ARBs try to prevent that cardiac remodeling.
Thank you for that. So then we can move. Okay. Kim is saying cardiac remodeling refers to structure and functional changes that occur in the heart in response to various physiological or pathological conditions. It can be both adaptive or maladaptive depending on the context. Okay, thank you. I guess we can move on to the next question.
Okay, before we move on, so we are saying ramipril has a cardiac remodeling effect, but it's a bad thing. But in this case, it's good because the person already has heart failure, so the heart is not pumping blood effectively. So when it causes that cardiac remodeling, it will improve the function of the heart. That's what we're saying.
Yeah, like it not, I don't think it reverses the cardiac modeling, but I guess it stops the heart to remodel like more, because we know that angiotensinogen is the one that causes, and ramipril, since it's being like it's an ACE inhibitor, it reduces the effects. Yeah, so it stops the progression of cardiac remodeling. Okay, you've understood?
Yeah.
Okay. Do beta blockers have remodeling effects? I'm not sure about that. Anybody else can answer that.
Yeah, they do.
Okay. Okay, fine. So we know beta blockers, but I think it's ramipril that's used mostly for the remodeling. Okay. The following drugs are appropriate therapies for lower urinary tract infection due to Pseudomonas aeruginosa except norfloxacin, tobramycin, cotrimoxazole, and ciprofloxacin. HP is saying B, tobramycin. Anybody else with a different answer or? Gas is saying cotrimoxazole. I think I would have also gone with that one, but I'm not too sure.
Tobramycin is aminoglycoside and therefore can be used for UTIs and lower infections. So we'll go with C.
Okay, thank you. Anybody else with a different answer? Clarification? Okay. So cotrimoxazole. Next question.
Maybe we can. I know
Sorry, do we have a tobramise? I thought it's only in eye ointment form. Do we have a tablet, an oral?
IV.
Okay. Okay.
Shina, you were saying?
if we could just remind the bacteria that cause UTIs, just chap. We know E. coli and Klebsiella. I don't know about the others.
There's Proteus mirabilis, E. coli, Klebsiella pneumonia, the Pseudomonas species, Staph aureus, Strep species, and Enterococcus faecalis.
Yeah.
Also, Candida can also cause, but of course not bacterial, but yeah, Candida can cause. AI has also commonly prescribed antibiotics, trimethoprim, sulfamethoxazole, then nitrofurantoin, ciprofloxacin, levo, and cephalexin, and amoxicillin. Okay, that's good. So we can move on to the next question.
No, we have never seen tobramycin being prescribed for Pseudomonas as in UTI. According to the venye umeongea pale, I've never seen tobramycin being written, but norfloxacin, cotrimoxazole, which is Septrin and Cipro, we normally do them daily, but surely tobramycin, no. Even if it's an IV, how many people will you prescribe for IV because of an UTI tobramycin, surely?
I think the issue is the Pseudomonas aeruginosa. Does cotrimoxazole have any activity against this organism? Because tobramycin does have.
I think that makes sense. We can continue.
Okay. Phenytoin is effective in the treatment of the following types of seizures except absence, generalized tonic-clonic, simple partial, or complex partial. Everyone is saying A, absence, seizures. Everybody is okay with that? I'm not sure, but I think for absence you use valproic acid and ethosuximide. Any other that you can use for absence? Somebody can also take us through epilepsy, please, or seizures. Anybody for seizures? Just anything, whatever you know, not everything. Okay. Seizures, I just know there's partial and generalized. Partial is simple, complex, and secondary to generalized seizures. For generalized, you have tonic-clonic, atonic, myoclonic, and absence. Mercy has sent an overview, of seizures. I think that is okay. Someone has also asked which ones are safe in pregnancy. You said, okay, gas assessment. Said liver, yes. Okay. Shina, is that okay? That picture is okay for you? Okay. So we can move on to the next question. Okay, the drug that can cause hyponatremia is number 18, C, carbamazepine. Everybody is okay with that one? Then the one that causes lesser side effects like hyponatremia is, what's the other drug in the same class? The one, it starts with O, something like that.
think
Yeah,
it's ox.
yeah. Oxcarbazepine. Yeah. Yes, that one.
Hiral, not disagreeing with the answer, but doesn't spironolactone also promote sodium excretion in urine, hence potentially can lead to hyponatremia? Like just asking on the same.
I think so. I'm not sure. Mary is saying no, is it sparing? I think it's only for potassium that it's a potassium sparing drug. But I guess I agree with you, like it can be spironolactone also.
Thanks. Yeah, bye.
So the answer would be B or C?
No, C is the best answer. C is the best answer.
Okay.
Yeah.
Okay. Okay, so the following is not a protease inhibitor. Lopinavir, abacavir, yeah. Abacavir is what? What's the class? NRTI, yes. And Liz is also saying rash and hyponatremia are the major causes of carbamazepine discontinuation. Yes. And carbamazepine also causes agranulocytosis. Okay, fine. An anti-epileptic drug that has the greatest effect on the efficacy of oral contraceptives is diazepam, phenytoin, ethosuximide, lamotrigine. Sam is saying for number 18, why did we go for C and not B in question? Why did we go for carbamazepine instead of not spironolactone? Guys, you can answer that, or Divya can answer that.
I think we said it's a matter of the best answer. That carbamazepine, it does cause that syndrome of inappropriate ADH, hence leading to hyponatremia. Like that's a major ADR of carbamazepine as compared to spironolactone.
I thought that ADR is most common in the elderly.
The ADR of hyponatremia.
Yeah, ADH, yeah.
Okay, I don't know about the distribution among the age groups, but let's just compare the hyponatremia between spironolactone and carbamazepine. It's just that carbamazepine would be the best answer there.
Oh, okay.
Yeah.
Okay, and James is also saying for spironolactone, hyponatremia is rare. Okay, thank you. So number 20, Is it B because it's a CYP inducer or inhibitor? I'm not sure about that. D. George is saying D, lamotrigine. Others are also saying B. George, you can tell us why you chose D.
Oh, there is an enzyme inducer that is okay. The antiepileptics that are enzyme inducers are carbamazepine and lamotrigine. So those will interfere with the contraception.
Isn't phenytoin also inducer, CYP inducer?
Phenobarb.
Chai, you were saying something?
I was just adding to that list. I was saying also Phenobarb is an inducer.
Yeah. So George, does that would also make B the answer? I'm not sure about lamotrigine. I know phenytoin is an inducer. Okay, fine. Then I would go for B.
Okay, I've just Googled,
Mm-hmm.
and you can use contraceptive injection coil safely with phenytoin. However, phenytoin may stop these contraceptives working. So combined hormonal contraception, you look out for bleeding before period, something like that. So I'll not go for phenytoin, but you can check, can just check on it.
Someone has also sent a picture on the group and it says lamotrigine and phenytoin both affect the efficacy of oral contraceptives. So I'm also not sure.
But we know phenytoin and carbamazepine are greatest inducer of microsomal enzyme. With any kind of treatment, phenytoin is one of the worst because of the enzyme inducing effect.
Okay, okay then we'll go for B then. Okay, for number 21, a tricyclic antidepressant that causes the most anticholinergic side effect is C, amitriptyline. And also, Pablo has said that the use of lamotrigine and an oral contraceptive increases the metabolism of lamotrigine and not the oral contraceptive. Okay, so next question. The primary goals of asthma therapy in an adult patient excludes maintaining normal activity levels, Is there an interaction between oral contraceptives with antibiotics?
Yeah, I think when you take antibiotics, your oral contraceptives can also the efficacy can be lowered.
Thank you.
It's because the oral contraceptives usually undergo enterohepatic recycling. Now, these bacteria in the intestine is usually hydrolyzed. You see, when the contraceptives have undergone phase 2 metabolism, glucuronidation, so these bacteria hydrolyze the glucuronide moiety, and then now they become lipid soluble, so they can be reabsorbed back. But then when we take antibiotics, then we do not have these bacteria to hydrolyze, so they're usually more soluble, so they can be excreted. Yeah.
Okay, thank you. Okay, so the primary goals of asthma therapy in an adult patient excludes maintaining normal activity levels, preventing destruction of lung tissue, control of symptoms, and avoiding adverse drug effects.
I think D.
Lydia is saying B, Rebecca is saying D.
Perhaps Rebecca can elaborate further.
You have no control over advanced drug effect, but when you're managing asthma, we have to control the symptoms that can exacerbate the condition. We have to prevent destruction of the lung tissue because of hypoxia. We have to maintain normal activity of every patient to carry out on their daily normal activity. But when it comes to avoiding advanced drug effect, we have no control over that. Because if it were going to use the LABA, the long-acting beta blockers or whatever, hapo una control yake. You cannot avoid. Patient will react according to their sex, genetic, whatever, but hapo hatuna control over it. That was my thinking.
I'm also for the choice D. However, based on the pharmaceutical care, prevention or minimizing or prevention of adverse drug effects are one of the goals of therapy of any disease management. But based on the choices there, I'd say choice D would be the least appropriate, would be the least outcome, or rather the last outcome that we are hoping for. The A, B, and C are the major outcomes.
So the answer is D.
Yes.
Okay. The
No,
list.
the answer is D, not B, kindly. Mama?
We can mark that question. The least likely trigger for asthmatic attacks is bacterial or viral pneumonia. hypersensitivity reaction to penicillin, discontinuation of asthma medication, hot, dry weather. Yeah, D. Anybody with a different answer? So D, yeah. Isn't dust a trigger?
I think I would go with C, because you know the implication is after you have an asthma attack, you're given your medication, yeah? So are we saying like once that medication has been discontinued, then it can trigger an asthma attack? Because I know asthma is not constantly managed, yeah? It's managed on an as-needed basis. So wouldn't C be an appropriate answer as well?
Divya is saying why not B?
For number 22. I was answering number
23.
Number 23.
Yeah, why not?
For number 22, avoid the side effects is a major factor. So we rule out D. D is a major primary goal of asthmatic attack. For number 22.
So George, you're saying the answer for number 22 is what?
I'll now go with B because B is a major factor. The major one is the limitation of symptoms. Then you prevent asthma attack and avoid side effects of asthma. So D cannot be answer to it if we eliminate.
Okay, thank you.
I have a question.
Mm-hmm.
Is there a difference between adverse drug effects and side effects?
It's the same thing, I think.
Okay.
My question too.
I think side effects are usually expected, but then I'm not sure. I think ADRs are unwanted, and side effects usually are from the pharmacodynamics of the drug. Yeah. I'm confusing ADRs with adverse effects. How many adverse drug reactions with the same?
Okay, there's a difference. The difference
Question
is
20.
ADRs are unexpected. You don't expect them when you give a drug at a normal dosage. Side effects is expected. It can happen to some people it cannot. So there's a difference.
We've just marked that question just in case. For number 23, I've seen many. Why not B? Someone said why not B, I think.
So
Others
I've checked for B. It's saying taking antibiotics within the first year of life may increase the risk of developing asthma. So can penicillin trigger asthma? So exposure to antibiotics early in life, especially antibiotics to treat respiratory infections, may lead to increased risk of asthma later in life. That's all I got.
Okay, thank you. So the answer would be C.
Okay,
This
for me, the answer is C.
C, okay. Anybody else with a different C? Okay, fine. Lydia is saying D because the trigger is cold weathers, not hot weathers. I saw someone say hot weather can cause inflammation, can trigger inflammation. Hot, dry weather can cause irritation of the airways, and I think this can lead to an inflammatory reaction. So C or D?
Let us just be realistic. Dry weather, mostly you'll find asthmatic cases during cold weather. But with hot air, surely when it comes to those Garissa side, Turkana side, you rarely get asthmatic attacks. But right now, when we have got this cold weather like this, those who are working in the hospital right now, we've got a lot of asthmatic cases, but not on dry weather. But discontinuation of asthma medication, it can lead to an asthmatic attack, especially those who are on long-acting corticosteroid. The moment you discontinue those kind of drugs, you might have to get an asthmatic attack. Asthmatic medication is a continuous medication for a long time, even if it's just the preventive, prophylactic drugs. But when you discontinue them, you'll get an asthmatic attack, but not dry weather. Let us just be realistic.
I agree. The answer is D.
Okay. We've just marked that question. Number 24, the triple therapy for peptic ulcer disease does not include cotrimoxazole, lansoprazole, erythromycin, amoxicillin. Cotrimoxazole?
A.
Yeah. I don't think we need to discuss. I think for peptic ulcer, it's the combination is used for lansoprazole, erythromycin, and amoxicillin. The following conditions may cause hypothyroidism except endemic goiter, Graves' disease, Hashimoto's, and thyroidectomy. Graves, yes. Graves is hyper. Yeah, Willie, sorry.
No. I was just saying B.
Okay. So Graves, yeah. I think we're okay. Just scroll down here. Okay. The following are causes of chronic kidney disease except diabetes, SLE, glomerulonephritis, long-term exposure to lisinopril or captopril.
I think D.
D, yeah. Anybody else with a different answer? Okay. I don't think we have to discuss anything in this. Anybody wants any discussion on this?
Yes, for question 26, why are we going for D as the answer?
You're saying why D? Which answer would you have gone for?
B.
SLE.
Because I think exposure to the S inhibitors also damage the kidneys. So, and that is chronic exposure. So,
Me, I went for D because, like in diabetes, the in first line treatment for a hypertensive patient that is diabetic, you go for S inhibitors because it is the safest for the kidney.
I think the drugs in D will lead to AKI and not CKD.
S inhibitors usually are nephroprotective in diabetes mellitus. That is very true. But in long-term exposure, they also damage the kidneys.
But lupus does cause chronic renal failure due to that chronic inflammation and highly oxidative state.
Okay, so we can then go for D, Basi.
Okay. The most common cause of liver cirrhosis, hepatitis A, E, alcohol, or renal dysfunction. HP is saying alcohol. Anybody else with a different? If there was a choice for hepatitis B, would that be the answer?
Yes.
No.
So alcohol is still the major cause of liver cirrhosis. Okay. Okay, the key organ involved in drug metabolism is the liver, we know that. Yeah. Which of the following statements regarding first pass effect is not true? It occurs in the GIT wall. It affects drugs that are administered orally, yes. It increases the mean residence time. It reduces bioavailability. Does first pass effect occur in the GIT wall? Okay. So
Yeah, because we have some CYP enzymes also on the Nini.
Okay.
Yeah.
Okay, so that makes C the answer.
Now, what is mean residence time?
I think without thinking about the mean, when you take drugs orally, it decreases the mean residence time, the time taken for the drug to be in the body. So if it could have been, it decreases the mean residence time, it could have been also an answer, but now it increases. Hakuna venye ita increase the residence time of a drug and you have taken orally and there's a fast pass effect already.
Okay. So the volume of distribution of a drug is used to calculate the loading dose not affected by plasma protein binding. is affected by multiple doses, not affected by adipose tissue. A here, I would have also gone with A. Which of the following drugs is absorbed from the gut? Mannitol, cholestyramine, racin, D, selegiline. I have a question for B. Where is it absorbed? Not absorbed. Okay, fine. Thanks. Even C is not absorbed, right?
Yes.
Yeah.
Those are alpha glucosidase inhibitors which are supposed to act on the is it the saccharides, so they're not absorbed, they're excreted and changed in urine, if I'm not wrong.
Yeah.
In feces, so they're excreted in feces.
Okay. All right. Okay then. The no side or adverse drug dose of a drug is greater than LD50. The threshold dose that produces the first adverse effect, the lowest dose that is therapeutically active, or the highest dose that does not produce any adverse effect. C, the lowest dose that is therapeutic. Why not D, the highest dose that does not produce an adverse effect? HP, can you tell us why you went for C?
What I think is, if you go for the highest dose that does not produce an adverse effect, that means even at the highest dose does not produce a therapeutic effect. When you withdraw the activity yenye inakuanga na LD maximum, ME, that curve. When you get to the therapeutic effect, which is an ME something effect curve, utaona chini ya hiyo therapeutic curve is where there is no side effect. When you start going above the therapeutic effect, unaanza kuwa na side effect, but it must be therapeutically active, but not that does not produce an adverse effect. How will you measure an adverse effect if you have not measured the therapeutic effect? That was my thinking.
Okay, so I'm seeing Pablo has said that that it's the highest dose or concentration level tested in an experiment or clinical trial at which no adverse effects were observed in the subject. So that would make D the answer. I'm also seeing on the group somebody has sent the greatest concentration or amount of substance at which no detectable adverse effects occur. So I guess D would make sense. So there are two things. There's the no L and the low L. Now the low L is which would have been. Okay. So then D. And Kigo is saying, isn't C the definition of minimum, is it minimum effective? Yeah, minimum effective concentration for dose. Yeah, I also think that. So I think D is the answer. Yeah. Drugs that are highly basic tend to bind to, yeah, the alpha. Yeah, and it's the acidic drugs that bind to albumin. Which of the following is an example of alpha-1 receptor blocker? Yeah, prazosin. Clonidine is which? Yeah, alpha-2 agonist. And propanolone is beta blocker. Great. And methyl dopa is also the same as clonidine, right? Yes. Okay. Which of the following is not a likely clinical manifestation of an organophosphate poisoning? Lacrimation, vomiting, meiosis, increased heart rate. Meiosis. I don't know about this one.
I think there was an error in that typing of meiosis. I think it's the dilation of the
dilation, yeah.
Yeah, but increased heart rate is not one of the organophosphates. It is, it's not, yeah. D could have been the answer if C was correctly written.
So D would be the answer, increased heart rate.
Yeah, it decreases the heart rate.
Okay. Opioid analgesics are used for management of diarrhea, cough, hypertension, severe pain. Hypertension, yeah.
Opioid analgesics are not used. Okay, so not used.
Okay.
Maybe I can ask on the same question because when you have an MI, myocardial infarction, sometimes you're told to use morphine. Morphine is also a vasodilator. At the same time, it is when it comes to management of MI, myocardial infarction, we are told to use morphine, and MI is one of hypertension is one cause of MI. I don't know, maybe we can discuss on that because management of opioids in hypertension, because sometimes we're going to use for as a vasodilator. In fact, it was one of the questions we were asked to check why we use morphine in MI, which is caused by hypertension.
I think on that, morphine, we use it, number one, the most important thing is the pain. It's a very good analgesic. The morphine also has that venodilator activity. It can dilate the veins, but that is just an added advantage of using morphine. We cannot use morphine or any opioid for that matter to manage hypertension it does have an advantage, but we do not use. Yeah.
What about cough? What about diarrhea? Because with the diarrhea, do you have pain in diarrhea? It's a side effect of opioids, which causes the constipation thing. So let's discuss about this, because when it comes to analgesic, you don't say we cannot use opioid for cough. Do we do? No, it's as a cough suppressant for opioids. At the same time, diarrhea is as it is because of the side effect of morphine that causes the constipation. But do we use it in diarrhea? Really?
Yeah, for severe diarrhea, we can.
I've sent something on the group on the uses of the opioid analgesic. And the uses are analgesia, cough suppression. We have antidiarrheal, acute pulmonary edema, anesthesia, and opioid dependence. So all the choices are there except hypertension.
Yeah, and although we can say loperamide is not an opioid analgesic, morphine is used for severe diarrhea. Morphine itself, it's used for severe diarrhea. So hypertension, I think for that one, we just opioids, we can't use opioids for hypertension.
But I think she can also be right, because they are saying opioids are recommended and frequently used in the acute phase of ST elevation, myocardial infarction. Yeah, is recommended. So I don't know whether, because loperamide, in this case, we are eliminating loperamide in use because it's not an analgesic opioid.
Okay, but now for this question, for number 36. So what are we saying hypertension is not the answer? What?
Reminder, we are talking about hypertension and not myocardial infarction. I think the two are actually different. George, different.
Gosh, I think we can proceed. You can proceed.
Okay, number 37, the most effective antidote for morphine toxicity is?
That's naloxone.
Atropine is used for what toxicity? If it's used. Okay.
Is it methadone that is used for the withdrawal effects? Or someone had just asked.
Okay, overdose of paracetamol causes?
Which drug causes problems with the stomach? Is it NSAIDs?
Yeah, the NSAIDs.
Okay.
What does paracetamol cause hepatotoxicity?
Someone has answered there in the group. They've said withdraw paracetamol. Oh, when is methadone used? Oh yeah, for paracetamol withdrawal. So I'll continue from here. So number 39. Which of the following agents is used in management of acute attack gout? What do you guys think? Colchicine. So can someone explain why they think so?
In acute management of gout. Can you hear me?
Yeah, I can hear you loud and clear.
In acute management of gout, we use colchicine, NSAIDs, and corticosteroids. These other agents are used for chronic management.
Thank you for that. Yeah, so colchicine is usually considered as one of the fastest ways to flush out gout. So for acute gout. I think that 9C. So number 40. The type of insulin with shortest duration of action. Allopurinol is used.
Regular.
Sorry, first someone in the group is asking, allopurinol is used for chronic gout. Colchicine is usually one of the fastest ways that you can flush out together with NSAIDs. Yeah. Someone was answering the question. Please go again.
I said regular insulin.
Yeah. What do you guys think? Yeah, that's the answer.
What
It's
about
not
aspart?
it's not aspart. Aspart is the ultra short active. Yeah.
Aspart is the ultra short.
5 to 10 minutes. Regular
Yeah, but the question is which one has the shortest among the choices?
That's what I'm saying. I think the answer should be B. Sorry about it.
Aspart.
Yeah.
Shortest, yes.
What is shortest and the shortest?
Aspart mean
Is the rapid acting insulin. You have the shortest duration.
Number 41. Which of the following parameters should be monitored in a patient on warfarin? Warfarin, everyone is saying choice A. Yeah, so that's true. I think you can measure that in the APPT for warfarin, while the PT is usually used for heparin. So I think we're good with that. I think for warfarin, you're mainly looking at the, is it the extrinsic pathway? And then the intrinsic for the PT. If I'm wrong, please someone just come in. So a drug that is not effective in the management of acute asthma attack is?
Excuse,
Yeah.
can you go back to question number 39, please? I just want to see the question. Not sure. Okay, thank you.
So,
I'm okay.
thank you. So for number 42, everyone has said A, chlorine sodium. Yeah, I think the others, theophylline, beta-2 receptor agonist, and the eucatropium. All of them can work acutely. If anyone wants us to talk anything about them, I think we've looked at them before. So we can go to the next question. An example of a diuretic that is potassium sparing is, I think this one we said many times, C. So number 44. The following side effects are associated with angiotensin II receptor antagonist, except, yeah, I think coughs, because we don't have bradykinin present in. So when someone has a dry cough, when they're using ACEs, they can shift to ARBs.
What about hyperkalemia?
I think they do cause hyperkalemia, if I'm not wrong.
How?
Because I think in most cases, when you find you have hyponatremia, then on the other side, you usually have hyperkalemia, if I'm not wrong. Like, that's how personally I usually know.
Perhaps just to add on to the same, is essentially we know the RAS system, renin-angiotensin-aldosterone system. So angiotensin will promote the release of aldosterone. What will aldosterone do? Aldosterone will lead to potassium being lost in urine and sodium being retained. So ARBs, which are inhibiting the action of angiotensin, it means less aldosterone is produced, meaning less potassium is lost. Hence, more potassium is retained in the blood. So hyperkalemia is a possible side effect with ACE inhibitors and ARBs.
Oh, so thank you for that. I hope you're good. So number 45, statins do not increase levels of low density lipoproteins, cause myopathy, reduce risk of atherosclerosis, or have a synergistic effect combination with bile resins. I think increase the levels of LDLs. Remember, LDLs usually are bad lipoproteins. So essentially, they usually transport cholesterol from the liver to the rest of the body and deposit it. Cough is side effect of ACE inhibitors, such as captopril, iso. So then you'll shift to losartan. So yeah, back to start choice A. The LDLs will transport the ACE inhibitor. The LDLs will transport cholesterol from the liver to the rest of the body and deposit there, and thus cause, hyperlipidemia or whatever. So we don't want our LDLs to increase. So choice A. 46, the drug used for radical cure of Plasmodium vivax infection is? Yeah, I think, as someone has said, Primaquine is usually one of our first-line treatments. So extra-intestinal amoebiasis can be treated with? Not too sure with this one. gas tells us choice D. Maybe someone can shed a bit of light on that in terms of how we'd treat the other forms of, and Brenda is also saying, can we briefly look at malaria management? So if someone can please share the information they have on malaria and someone else on amoebiasis. Anyone can give it a go. Rebecca, Gas, feel free.
I will have gone for chloroquine. I checked the other day on extra-intestinal amoebiasis. I don't know why they chose. They were taking metronidazole and chloroquine. I'm answering number 47.
Yeah.
Okay.
Yeah, someone is in the group is also saying luminol and extra intestinal we use metronidazole. Maybe someone can share why they chose the answer that they chose, please. Chloroquine is for extraintestinal only. So I think we can put chloroquine as the answer, and then maybe each of us can look at it later. It's fine. So number 48, the drug of choice for eradicating schistosomiasis is it would be nice if people would mchangamke.
I have a question.
Please.
Sorry, what did you say? Why can't we use A for 47?
I think people say because chloroquine is usually used only for, like, its indication is strictly extraintestinal amoebiasis. So
Okay, let me answer that question. I've got my notes for tissue amobicides for both intestinal and extra-intestinal. We have got nitroimidazole, which is akina metronidazole, tinidazole. But wamekota hapo NB for extra-intestinal amoebiasis, only chloroquine. It is in our notes. Only chloroquine. But for luminol amoebiasis, now we go for diloxanide. Luminol, it is diloxanide. We have got hydroxyquinolones. We have got antibiotic like tetracycline, paramomycin. That is for luminol. But for extra-intestinal, it is NB, quoted in NB. It is only chloroquine. Those are from our notes.
Awesome, thank you for that. Shreen, I hope you're good.
Yes, thank you.
Oh, thanks. We'll move to the next question, number 48. The drug of choice for eradicating schistosomiasis is, I think, praziquantel. Someone has said in the group. And that's because I think it can be used to eradicate all forms of schistosomiasis. Oh, yeah. Sulfonamides act by? Yes, if someone can. So B, interfering with the utilization of folic acid. Yeah, I think we know that it usually inhibits the P-aminobenzoic acid, the PABA. So, which of the following compounds inhibits bacterial or Sarusis? Check what's up. So yeah, I've seen someone has shared malaria. Maybe we can just look through it at our own time so that we can cover more ground. Or would you want me to read it out, Saru?
No, I was answering Brenda.
Oh, sorry. So, which of the following compounds inhibits bacterial cell synthesis? Yeah, polymyxin B. So I think those ones we good. D, sorry, D. Oh, no. I think it should be. Oh, no, it's not D. The one is saying B. Dala. Oh yeah. Yeah. So for vancomycin, it binds to the portion of the growing cell wall. I think I'd mix it with polymycin B, which actively affects the cell wall. Yeah. So we can go to the next one. The immediate natural precursor to cholesterol in animals is what do you guys think? B, I guess so I'd also go with the same thing. Who? So I think we're good with that.
Not, I thought agosterol is for fungus. See, we are animals, and we don't have a.
Only the bacteria and the fungi, not the animals, surely.
Yeah, correct. I think this is enough the late limiting step for the statins. Conversion imevalonic to what?
It is better A, but not agosterol.
Although they are almost structurally similar, cholesterol and cholesterol.
Yeah, true. Hey, sorry. What term is used for small molecules that bind to different regions of a binding site? Nasi. I think it's not the immediate precursor. Maybe someone can tell us. Gas.
Yeah, I agree with you. It's as Chai has said, we have that HMG CoA to mevalonate, then all the way to cholesterol. Like those are the main ingredients.
What term is used for small molecules that bind to different regions of a binding site? Epitopes. Yeah, I think the answer is D. Epitopes bind to the same regions of proteins, triggering a cellular immune response mediated by T or B cells. So the adrenergic agent whose structure is shown below. I'm not too sure about that one. Okay. So Yeah, that is propanolol with two benzenes. So number 54. The following amino acid have a side chain containing a basic group except. I think I'd go with arginine. Is it arginine? Oppo says C. What do you guys think?
Histidine, lysine, and arginine are basic.
Histidine, lysine, and arginine. So everyone says C. The vitamin that contains a cyanide group coordinately bonded to a cobalt atom is. Oh, Pablo says I'm too fast. Sorry, Pablo. Do you want us to go back? Please share your thoughts.
Is it possible to give a small rundown from, I think, number 51, if that's possible?
So maybe she can go up a bit. Shrina, maybe you can go back to number 51. So here the immediate natural precursor to cholesterol is in animals is, so we said egesterol is mainly in fungi, and mevalonic acid is converted to mevalonate, then cholesterol by the HMG-CoA enzyme. So mevalonic acid was our best choice. Acetyl-CoA, we said it's a precursor, but it's not an immediate natural precursor to cholesterol. Yeah, and mevaldic acid, I'm not too sure. Maybe if someone has information about mevaldic acid, they can share. What term is used for small molecules that bind to different regions of a binding site? Here we went with epitopes, because epitopes are when we're talking about molecules that can bind to different areas of antibodies, therefore, leading to the release of T or B cells.
Really?
Yeah, Nambe.
Your number 51, I go explain what you mean or your understanding of natural precursor. Like, what is your understanding?
So basically, you have the whole process of how cholesterol is formed. Sindio? So all the things in all the steps are precursors leading to the formation of, so for example, for cholesterol, one of the first things that we'll have is acetyl-CoA. And then acetyl-CoA, HMG-CoA. And then we have mevalonate all the way to cholesterol. So all those in each step is a precursor. but we are talking about the immediate precursor in our choices before we get cholesterol. Are we together? Yeah. So kila kitu kwa hiyo step itakuwa precursor, lakini ile yenye inakuja tu, we wanted the immediate. So out of the choices that we have, which one is closest to, yeah, exactly what Sarafina Sari is saying. Yeah, the one which is closest to our cholesterol, that's what we want because it's the most immediate. Sindio? So for number 50, for number 53, we said the adrenergic agent present in that picture is propranolol. I think that one you just have to look at the structures. It's more of a hit or miss. So Shrina, we can go to number 54. The following amino acid has a side chain containing a basic group except. So I think here we said arginine, histidine, and lysine all contain basic groups except cysteine.
Perhaps on that we can look further on the aromatic amino acid, the non-polar amino acids. Yeah, because I think that would help in that. With that.
Yeah. So can someone give it a go? Is someone vast? You've written it down somewhere? I know for the aromatic ones, I think we have tyrosine, histidine, tryptophan, and phenylalanine. I think those ones
I
are the ones.
can
Yeah, please.
I can read out.
Tell us.
Can I continue?
Yeah, muted. Please go ahead.
Pardon?
Yeah, go ahead. Go ahead.
We have 20 amino acids that they are structurally and chemically grouped in as below. The L-alpha amino acid present in proteins include glycine, alanine, valine, leucine, and isoleucine. Then the hydroxyl group containing are we have tyrosine. We have serine and threonine, and sulfur containing we have cysteine and methionine. And the side chain containing acidic groups or their amides, we have aspartic acid, asparagine, glutamic acid, and glutamine. Then the basic groups, we have arginine, lysine, and histidine. Then aromatic group, we have phenylalanine, tyrosine, and tryptophan. That's all.
Also, thank you for that. I think even Chai has shared them on the group. So in case you want to have a review, you can look at the image that has been sent. So the vitamin that contains a cyanide group coordinately bonded to a cobalt atom is, I think that's cyanocobalamin. That's A. Yeah, I think we've looked at the vitamins quite a lot. So the following compounds have an indole nucleus except serotonin, lysergic acid, diethylamide, sumatriptan, or thiophyllene. Someone is asking D. What do you guys think? Maybe someone can share why they think so.
Why not serotonin?
D is a purine. Why not serotonin gas?
It's just a matter of structure. So the indole, we know the indole nucleus, how it looks like. Is that a benzene attached to a pyre? What's that called? Pyrrole, yeah. And the structure, if you just look at the structure of serotonin, you'll see that it has something in those, it has that nucleus. So here, it's just a matter of knowing now the structure. But
Yeah, I think even the chemical structure itself has.
Sorry. I thought which one has butanidol. Sorry.
It's okay. So which analytical test is carried out by ignition of concentrated sulfuric acid? Does someone know how the sulfated ash is carried out? May I see the previous question, please? Shrina, can you show number 56? Yeah, but I think when you're carrying out sulfated ash, you ignite the sample while you're using sulfuric acid. So that should be our answer. Sindo. Does anyone have a problem with that? So number 58, an example of a protic solvent is? So basically for protic, we want to donate a protein, a proton. So preferably the H plus. So we want an acid we'd preferably want an acid to donate our H plus. And here we have acetic acid. So from the OH, the H will then be donated. So I think our answer is B. So the following drugs are nitroimidazoles, except yeah, I think mebendazole. The others are nitroimidazole. We have metronidazole, tinidazole. Mebendazole is benzimidazole. So, which of the following antibiotics is not derived from an amino acid? I think that's streptomycin. So Nitrox is asking examples of protic solvents. So just from the example, from the explanation, I think all acids in an acid-base reaction would act as protic solvents, in that they would donate the proteins that they have, the protons that they have to. Are we good? Are you okay? Do you understand? So we'll just give you answer in the group chat. So thanks. higher. Which of the following antibiotics is not derived from an amino acid? I think D. Yeah. Yeah, we know that streptomycin is from the Streptomyces crisis. So very good. The following instrument operation module in ultraviolet visible spectrometry is of the following sequence. So we have our
Your Willie.
yeah.
Number 60, yeah, beautiful is not derived. Why, like, why have you landed on that streptomycin?
Oh, because I was thinking that it's isolated from the streptomyces. Amma, what did you think the answer is?
Not okay. It's because also I know cephalexin is semi-synthetic, oxacillin, same. Okay, like I don't know about amino acids. I thought perhaps there's a specific reason why streptomycin, or rather why not the others, but ni sawa tu.
What would you give as your choice? But I do understand where you're coming from, because the others are semi-synthetic, because they were all found at the same time, Sindio. And they were derived first from the strepto. Yeah.
Okay, no, currently chloramphenicol is produced synthetically, but okay, I guess that question, it's more on the source of those antibiotics. So I'm not, perhaps if we could highlight just the sources of cephalexin, chloramphenicol, oxacillin, and streptomycin. I'm not even saying that streptomycin is wrong or right. I'm just
No, I completely understand. Yeah, I completely
yeah.
understand. So for cephalexin, I'm seeing for the synthesis, usually like you react amino acids to form it. So the 7-amino cephalosporanic acid with mixed anhydride and just some other reactions. So for that one, maybe we can kick it out. That one you've said it's currently fully synthetic. Sindo?
Yeah, but it's also natural. Let me see from which organism and what's the product. Phenylalanin. Okay.
For oxacillin, I'm not finding. Have you seen? Because they're currently saying, yeah, right now it's semi-synthetic, but they're not saying exactly how it's being synthesized. But maybe
all the beta-lactams. All the beta-lactams are amino acid synthesized.
Yeah, and in the group, George says streptidine for streptomycin. So maybe we can all look at it later. There's a star on the paper, so when you're going through, you'll give it
The
another
answer
look.
is for that question. The answer is chloramphenicol, since AI is saying that it's a synthetic antibiotic, which is to mean that it's chemically synthesized rather than being derived from the natural amino acids.
Awesome. So maybe you can change. Amma, do you have any objection to that, guys?
Honestly, I don't know. I don't know. I was just inquiring. Yeah, but based on what we've discussed, I thought streptidine is more of a sugar, so I'd also go with D. But now, based on what Chai has said, I'm not sure.
So I think we can look at it later by ourselves. Alafu we'll come back to it. That's good. Sindio. Number 62. An atomizer is unique to. I'm not too sure. I'd go with C because I know we usually use flame detection. But what do you guys think? B, someone is saying the infrared. I'm not too sure, but do I remember it? I think we were mainly using the electrochemical and the flame spectrometer as a detection method.
What I know this may not be popular, but what of choice A?
Chromatogram. Personally, I haven't seen cases where that was being used, but maybe you can tell us more.
Because I'm seeing an atomizer is essentially a spray, and in stuff like TLC, we do spray after the development of the chromatograph. We spray with even with the alkaloids, we were spraying some type of reagents so as to see those spots.
Yeah, because they usually had those graphite tubes or something. No.
Yeah, yes, yeah, but with spray, in short.
Yeah.
Yeah.
Ego says the answer is flame photometry. Me personally, the way, like I do understand what you're saying, guys, but I think mostly, like I was always, when I was looking at it, I was always finding that flame, like the flame, either the flame or the electro thermal indication. So I think, yeah, but I do know that both of them actually, so I'm not very sure.
Okay, thanks. I've seen Professor Kigo has said it. I can't argue.
Yeah, true. Yeah. So, do we have MS and AAS? Do MS and AAS have atomizers? I think when you're talking about spectrometry, I think those are your detection methods, and here we're talking about the whole procedure, but parts in IR, yes, they do. What do you guys think? If someone can look at the chart and someone is asking, does MS and AAS have atomizers? What do you guys think? So, the answer has been given in the group. So number 63, the classical infrared spectrophotometers, which operate in the spectral frequency range of I think it should be 4,000 to 400 monitor frequencies in think this one we said it was mid IR. So, which of the following is not commonly used as a solvent in UV visible light spectrophotometry? What do you guys think? So someone has shared common solvents for UV and visible spectroscopy are water, ethanol, heptane, hexane, and chloroform. Yeah, so I think we'll rule out methanol from those. Are we good? So I think we can stop there, if that's okay with everyone. And then we meet at 4.